All right, so let's talk about mastocytosis. So this is going to be a pretty natural extension of the mast cell lecture, but it's going to talk about mast cells in the context of being a sort of specific pathology. So let's get right into it. You can pause here to see the sort of overview and learning objectives, but I'm just sort of going to jump into it and talk about mast cell development. So as we know, mast cells derive from these sort of precursor cells that are positive for CD34 and also for 117. Now CD117 is also known as KIT, and KIT is the main sort of receptor on mast cells that interacts with stem cell factor, or SCF, to promote their survival. And also is involved in their maturation and differentiation as well. So this process is supported by cytokines such as IL-6 and IL-3. And as we know from the mast cell lecture, if you have dysfunctions in the KIT receptor, the mast cells are going to undergo apoptosis. So it's a really essential receptor. So this is sort of a refresher just to sort of set the stage for how this growth can get out of control. So let's talk about that. We could say broadly that mastocytosis, which is a sort of clonal mast cell disorder, so mastocytosis and many of these other related clonal mast cell disorders, many of which are related to sort of various cancers and neoplasms, they all come from mutations or dysregulations in signaling pathways that control proliferation. So much like cancer, these clonal disorders are a result of rampant out-of-control growth that is happening at the level of signaling. So one of these ways is through gain-of-function mutations. So we have a proto-oncogene KIT, right, the KIT gene that is resolved or involved in growth. So that's why it would be a proto-oncogene. So if we have a gain-of-function mutation, such as the D816V, which is a point mutation, this is going to increase the amount of growth signals that are sent by the KIT receptor, so much so that they are essentially functioning as constitutively activated receptors. So that's that's a way of saying if you have this gain of function point mutation, it's like that receptor is firing at all times. You're going to get a ton of mast cells. But we also see other things in the other direction, such as anti-apoptotic proteins, such as BCL-XL or BCL2, and these are also increased in mastocytotic bone marrow. So these are some of the ways that we can sort of get out of control mast cell growth. What does this actually look like in a patient? We are going to have a ton of mast cell mediator release, and this is very familiar from various lectures on allergic inflammation, a lot of other atopic diseases. So I won't really summarize these. You can read these if you need a refresher. But some of the things that help to sort of differentiate mastocytosis clinical symptoms from other atopic diseases is that it's really focused in the skin and the GI tract, and then you also see involvement of the liver and spleen and bone marrow as well, and a little bit of the skeletal system. So while the skin and GI tract are sort of overlaps with other atopic conditions, the sort of liver, spleen, bone marrow, and skeletal system are not something that we see a lot. And unlike allergies and anaphylaxis, we don't actually see a lot of respiratory involvement either. I'm not sure why entirely, but yeah. So the main reason I want to bring these up is to show you the general range or the systems that the mastocytosis is going to be affecting. And we're going to discuss the skin and the GI tract specifically. So when it's in the skin, it's called cutaneous mastocytosis, and this is the most common manifestation of mastocytosis. And it's also known as urticaria pigmentosa, or maculopapular cutaneous mastocytosis. So a lot of names describing the same thing, but it basically results in these sort of lesions across the skin. And these lesions can be monomorphic, which are means they are small and more uniform, or polymorphic, meaning they're variable in size and variable in shape, and that's going to be more common in children. And typically people with these lesions are going to, have extreme swelling, itching, and redness that leads to something called Derrier sign, which is portrayed down here. And something that we see just sort of off lab samples is that dermal mast cells are going to increase by a factor of nearly 10 times their normal value. And that is going to be a diagnostic criteria for cutaneous mastocytosis. It's just seeing a crazy high number. So sorry if this is something that is sort of off-putting to you, but there's also diffuse cutaneous mastocytosis. So this is going to be something that comes a little bit before, or I should say it's early onset. So before 3 years of age, typically a child is going to start developing signs of this. And this is really just caused by overwhelming and generalized and diffuse mast cell infiltration. And you get this sort of yellowish brown or orange peel appearance across your entire skin, and it can result in bleeding, bullous eruption, and unsurprisingly, infection. So you can see what that might look like. This is sort of the orange peel-like skin, and this is sort of these blisters that tend to form on the skin. Now, in the GI system, you get a lot of acid reflux, and so this is why H2 receptor antagonists, such as H2 antihistamines, are going to be really effective in resolving this pain. But you get a lot more GI symptoms here than you would in perhaps another type of atopic condition, such as food allergies, for example, because in those cases you still would see some GI symptoms, but not nearly as much as this one. Another thing is we see evidence of malabsorption, various nutrients in around a third of the patients, especially vitamin B12, and that's due to mast cell infiltration in these sort of small intestinal mucosa. And next we're going to talk about hepatic and splenic involvement. So we see hepatomegaly and splenomegaly are pretty common in mastocytosis. So around 61% of patients are going to display some sort of liver disease, and we see high levels of alkaline phosphatase sort of floating around the body, or ALP, and that's associated with hepatomegaly, splenomegaly, and liver mast cell infiltration. So this is a large contributor to when mastocytosis becomes very aggressive and potentially fatal. So often if it's just the skin or the GI system, you're not going to see as much mortality. But when you get those really severe cases, it's going to often be these bigger organs that are involved. So talking about how we classify it, as we do with many diseases, we can say maybe at the broadest level that there is either cutaneous mastocytosis, which is going to result in these urticaria pigmentosa lesions or the mastocytomas in the skin, or it could be systemic. So cutaneous is relatively easy to diagnose. Again, you can look at things such as the level of dermal mast cells, but I'm really going to talk a little bit more about this diagnosing systemic mastocytosis, because this is where you need to really pay attention to certain criteria. So to diagnose systemic mastocytosis, you need one major sign and one minor sign, or you could have 3 minor signs. So the major criteria is dense infiltrates of mast cells in the bone marrow or another extracutaneous organ. So again, extracutaneous meaning not the skin. And if you're wondering what dense infiltrates actually means, well, there is values, but I'm sort of excluding them because they're not the most important to understanding this. Now, the minor criteria, again, you can have any one of these and those dense infiltrates, and you'll have systemic mastocytosis. So the first one is abnormal morphology of mast cells in the bone marrow. So they look at the way that the mast cells are structured, what receptors they're portraying, and if they're abnormal, that is potentially signaling that something with their differentiation and growth is not right. We see obviously those activating point mutations that are leading to overactive KIT receptor function and signaling. We see mast cells with an IL-2 receptor in addition to their normal markers, and we see persistently high serum tryptase, which again is released exclusively by mast cells. So let's say you've diagnosed someone and you know for sure that they have systemic mastocytosis. Well, now it gets a little bit more complicated, so we can classify those patients into indolent, smoldering, and aggressive phenotypes, or ISM, SSM, and ASM. And the way that you do that is you count how many B findings they have and how many C findings they have. And these B findings are sort of the more severe ones, and the C findings are the less severe ones. So let's go over these. So the B findings are going to be bone marrow biopsies, extremely painful, by the way, that show high infiltration of mast cells and high serum tryptase. You can also have mast cell dysplasia, which is mast cells that are growing in tissues they don't normally grow in. And you can also have hepatomegaly that doesn't have signs of liver dysfunction. Or you could have palpable splenomegaly without any signs of hypersplenism. So really this last criteria is saying that they're physically enlarged, but the function is not entirely gone yet. Now, the C findings are more so just more severe versions of this. So you could have bone marrow dysfunction that is caused by that mast cell infiltration. You could have hepatomegaly with impairment of liver function. And you can also have skeletal involvement with bone lesions. And you can have splenomegaly with hypersplenism. So yeah, these are the B findings, these are the C findings. So if you want to sort of count them up, well, indolent is going to be one B finding, so that's the sort of the more severe one, and then none of the severe findings. Smoldering is two of the B findings, but none of the C findings. And then aggressive is basically if you have any of those C findings, that would be classified as aggressive. So those were sort of the theoretical WHO guidelines on how to classify it. But as far as diagnosing it goes, you would need to actually sort of obtain a lot of those values. So we tend to look at things like symptoms, which you can see here, physiological mediators, biopsies, genetic factors. So biopsies are useful because those are really helpful to just count up the mast cells in the skin, and that can help confirm cutaneous mastocytosis. Bone marrow biopsies are really useful for getting those B and C findings, even those major and minor criteria, and helping differentiate various subtypes. And then obviously those genetic markers are very valuable, especially the codon 816 mutations, because those are pretty easy to spot based on the degree of clonal expansion from that original neoplastic progenitor. As far as physiological markers that we're looking for, serum tryptase is a sort of standard surrogate marker that you would take via ELISA, and this is really going to correlate strongly with the likelihood of how many organ systems, I should say, are involved. Serum and urine histamine or various metabolites of histamine are useful. Arachidonic acid metabolites are also very helpful because they can suggest mast cells even if they're not exclusive to them. And then we can also look for soluble KIT receptor and CD25, which are seen much higher or elevated rates in mastocytosis. And finally, just for treatment, unfortunately, since this disease is a lot newer, the current treatment is not very specific to that disease, but we see things like mostly just H1 and H2 antagonists, chromalin sodium, which is a mast cell degranulation inhibitor, ketotifen, which is a mast cell stabilizer that also prevents degranulation. Since it can result in hypotensive episodes, sometimes epinephrine is good, treating it as if it were shock. And then, interestingly, people have also used ultraviolet photochemotherapy, which is sort of a chronic therapy that helps to decrease the dermal mast cell count. So I know this sort of presentation is a little more bare bones, like there isn't a ton of information, but I think mastocytosis is a really interesting disease because so much is remaining to be discovered about it. So if this interests you, I really encourage you to do a little more research into it and see if it's something you might be interested in pursuing down the road.